Morning, everyone. I'm DrKirtiNaranje. I'm additional professor in heading the Department of Neurology at Sanjay Gandhi Postgraduate Institute of Medical Sciences. Today, I'll be talking about a very unique thing that's practicing neonatology day in and day out. That is the surfactant replacement therapy in babies. In the last 4 decades, advances in neonatology have led to a significant increase in survival of preterm infants. And one of the biggest advances was the introduction of surfactant replacement therapy for the treatment of respiratory distress syndrome in preterms. So I'll be covering my talk under the following headings. My talk will be more of basic learning and current evidences related to the practice of surfactant replacement. So I'll be giving a brief historical background. Typical case-based discussions will be there. And then I'll review some of the surfactant therapies, mechanism of action, types, techniques, the complications related to it, backed by the current evidences, and in the end we'll have the take-home messages. So throughout my talk, I'll be referring to these guidelines because has been just recently been published by National Neonatology Forum in India about the surfactant replacement therapy in babies. So what is the surfactant? The surfactant is a substance that coats the inside of the lungs and it prevents the small air sacs, like the small alveoli, which are the terminal and bronchial alveoli, from collapsing. And as we know, the majority of the productions begin during the late trimester of the pregnancy, that is during the 3rd trimester, and hence the babies who are born very preterm do not have enough surfactant to maintain their air sacs from collapsing. So therefore, they develop respiratory distress syndrome, which was initially also called as Highland newborn disease, soon after the birth. And in this, surfactant replacement therapy is the crucial part in the management. So a brief historical perspective. Was Nygaard in 1929 who first thought and put forward the idea that the refractive forces of the lungs depend upon the surface tension of the alveoli. And this could be the reason for the galactosis in newborn lungs and probably one of the important causes for respiratory distress syndrome in preterms. However, it was not until 18 years later the group had repeated these experiments in the stillborn infants, in the lungs of the stillborn infants. And despite the knowledge that what was the reason for RDS in this preterm newborn babies, the much of the progress was going very slowly towards this direction, and no major focus was given to this problem to be overcome until a tragic event occurred, and this event remains the sad chapter in the history of surfactant replacement therapy. So in 1960s, as we already know that the then U.S. President John F. Kennedy's baby died at Boston Hospital because of respiratory distress syndrome. The baby was 35 weeks and was born premature because of placental abruption. The baby, and despite the latest advances at that time for neonatal care, the baby died. And this led to the focus to the trials involving surfactant, and this is how the boost or the speed towards the progress of use of surfactants began. And in the early 1960s, late 1960s, the first clinical trial with synthetic surfactant began. However, it was the introduction of natural surfactant began in the early 1970s, and it was Dr. Fujiwara's experiments with natural surfactant in 10 newborn babies, preterm newborn babies, where he used the first natural surfactant, and this landmark article was published in Lancet in 1980s. That led to the rapid trials with the use of natural surfactant in preterm babies in prevention of in treatment of respiratory distress syndrome. So this experiment was done in 10 infants, more than 1,500 grams, and 80% success rate was there with the natural surfactant. So this is how the story of the evolution of surfactant therapy in RDS is. I'll be discussing a typical case in the next section. So this was a baby, 29 weeker, 1 kilos, appropriate for gestational age male child. Was born to a 30 years old mother. Mother has received antiviral steroids and was born by emergency cesarean infection because of severe preeclampsia in the mother. The baby cried at birth and delayed cord clamping was done. The upguards were 7, 5 and 10 minutes of life. So the initial management at delivery room, at 10 minutes the baby had respiratory distress with rates going up to 70% retractions, decreased air entry and venting and saturations going off oxygen below 80%. The Silverman Anderson score of release in terms was around 6. So this video will show how we score the respiratory distress in newborn babies, and this is a typical preterm baby with RDS. You just have to listen to the sounds that we make and it will make it easy to diagnose them.
Baby is fainting. Select green. Preventing is baby's attempt to maintain alveolar volume by prolonging and increasing expiratory pressures by breathing against a partially closed glottis.
So this is how typical RDS baby with severe distress will look like. And for scoring severity of the Silverman Anderson's respiratory severity score is an easy, quick, and non-invasive method to assess the newborn distress. So there are 5 parameters that we assess, which include retractions of upper chest, lower chest, nephroid, the nasal flaring, and the expiratory tract. So depending upon that, the severity score we grade from 0 to 2. So as can be seen from the diagram on the picture. And anything more than 6 is impending respiratory failure, and in severe respiratory distress, the maximum score can go up to 10. So the initial management in this baby, in the delivery room, it started with 5 centimeters of CPAP with FIU of 30% using the CP resuscitator, and the baby was shifted to an ICU in half an hour of life, continued on CPAP, and he was put on the ventilator CPAP. So this is the device where we usually give CPAP or positive pressure ventilation in the delivery room, which is called as a resuscitator, and it is an excellent device because it does not require much of electricity, or it is basically totally flow-driven device, and you can give precise positive pressure ventilation using you can do precise peak expiratory pressure, precise positive and expiratory pressure as well. So we can use this device for giving both PPV as well as just peak. So this is a very useful device, mainly used in the labor rooms and delivery areas. And if you do not have this, you can use simple double CPAP assembly as well for giving positive pressure in RDS babies. So a brief about CPAP. What does the continuous positive airway pressure does is in RDS, it decreases the work of breathing by preventing collapse of alveoli, because it gives the positive end expiratory pressure and thus keeps the alveoli open. It decreases the ventilation perfusion mismatch and conserves surfactants. Overall, thus there is a decrease in work of breathing. Its use has also been studied in apnea, where it stabilizes the upper airways and brings the air, and therefore apneas may be also prevented. So this is a typical chest X-ray of a baby with respiratory distress syndrome, where there is a hypoaerated lung and the ventricular a typical whiteout kind of lung you can see. You can also see some hair pneumothorax and diffuse ground glass appearance. So this baby was put on a CPAP of 8 and FIU to increase up to 40% because of persistent distress, and at this time we considered giving him surfactant, and we gave him the surfactant administration and then followed by continuing on CPAP. So a slide about evaluation, the management strategies of RDS over the last 4 decades. So as we have seen earlier, in early 1980s, surfactant replacement has come into the practice. It was in 2000s that the role of continuous positive airway pressure was also established, and now since 2008 this practice of the practice is basically to give early CPAP followed by surfactant if required. So you can see the practice of surfactant technique has evolved over years from administration. So in addition, there is role of antiviral steroids and caffeine therapy, which has come into the practice and now it is the standard of care in prevention of respiratory distress syndrome. So a word about antiviral steroids. Antiviral steroid, what it does is it induces the type 2 pneumocystis and which increases the surfactant production. And the maximum efficacy is before delivery is between 2 to 7 days after the administration of antiviral steroid. It is administered in less than 34-week babies, and the choice of drug in India is dexamethasone, where we give 4 doses of 6 mg intramuscularly 12 hours apart. And thus, this will give you the overview. So, actually, what is the current standard care of treatment is in any preterm babies with RDS is to initially stabilize the baby on continuous positive airway pressure, and then give selective surfactant replacement therapy if required. And all of this should be also supported by your supportive care in your neonatal intensive care unit. So, what is actually a surfactant? We will now review what is surfactant, what mechanism, what are the types, timing, and everything. So, first thing is the surfactant properties. What is a surfactant? Surfactant is a complex mixture of lipids and protein that reduces the surface tension. And it contains mainly, it is composed of 90% of your surfactant is composed of your phospholipids, of which around half is by saturated phosphatidylcholine choline and the rest is by other phospholipids like phosphatidylcholine glycerol and unsaturated phosphatidylcholine. Only 8 to 10% is composed by your surfactant proteins, which are A, B, C, D, and A is the predominant surfactant protein. So as you can see in this diagram, this is air alveolar space, and then this is your alveoli. There is some lining in the aqueous space in this alveoli, because in utero the lungs are filled with water. So once the baby is born, the water needs to get absorbed and it is to be filled by your air. But in absence of surfactant, the alveoli are trying to collapse at expiration, and hence it is not inflated. The type 2 pneumocytes are in the linings of the alveolar space in between the aqueous space and the air space, and from where it secretes your surfactant and it helps in maintaining the shape. So what happens in preterm? There is a less saturated phosphatidylcholine, there is a decreased surface activity, and they contain more phosphatidylcholine than phosphatidylglycerol, and thus it indicates there is lung immaturity or there is the injury to type 2 cells. So if we compare the surfactant pool in amongst adults, term and preterm babies, so we can see that the preterm babies have very less surfactant pool size, less than 5 mg per kg, as compared to the term neonates, which is around which have around 100 mg per kg. So all of these factors will lead to the respiratory distress in the very preterm babies. So how now we will see how the surfactant acts. So before that we should understand this law of Laplace. Many of you must be aware of this law. So what is law of Laplace? It describes the surface tension by meaning that what is surface tension is that it describes the tendency of a fluid to minimize its surface area. And this relationship is given by this law of Laplace, which states that the pressure is equal to 2 times your surface tension divided by your radius of the alveoli. And the normal alveoli obey the law of Laplace. So, actually, whenever there is a high surface tension, what happens is there can be 3 problems with the alveoli. One is that whenever the lungs are not open, or their lungs are not open and they are empty, the compliance falls, and as the radius also falls, the pressure required to open the alveoli increases at the given surface tension, and all of this will increase the workout rate. Secondly, smaller alveoli require greater transmural pressure to remain open, so as compared to your larger alveoli. So there is a pressure difference between the larger alveoli and the smaller alveoli. Hence, there is a tendency of smaller alveoli to get emptied into the larger alveoli in absence of surfactant. Then there can be third problem about fluid presence. Because of high surface tension, there is a tendency that the fluid from the interstitial space can go into the alveoli, which can lead to pulmonary edema. So all of these means there is a high surface tension, and all this is detrimental to your lung. So this is just a diagram which is showing that normal expiration with adequate surfactant level. So at the end of expiration, all the alveoli are open, but without surfactant, there is one alveolar collapses, and on this will increase your workout rate. So coming to the timing of the surfactant therapy. So when are you going to consider surfactant? So whenever there is a persistent severe respiratory distress with your positive end expiratory pressure more than 8 centimeter of water, and your FIQ requirement on CPAP is more than 40%. So in order to maintain a saturation more than 90%, you require more pressure requirement as well. At that time, you should consider giving surfactant to this baby. So timing is, classically it is described into 3 parts, like early rescue within 2 hours, late is after 2 hours of birth, and prophylactic is classically described in less than 26 weeks. Prophylactic is before the baby develops respiratory distress. If he is very preterm, you give surfactant irrespective of distress is present or not. So what does the recent guideline say? That the preterm 7-34 weeks of gestation, selective surfactant administration should be given. So what is selective surfactant administration? Is to first stabilize the baby on continuous positive airway pressure. And if their requirement increases more than 6 centimeter of water of positive expiratory pressure, or an oxygen requirement of more than 30% to maintain saturation of more than 81%, then you give surfactant administration intraperitoneal. And in those babies who get intubated in delivery room because of either increased respiratory distress, then delivery room surfactant can also be given then and there itself. And early ensure, that is early rescue therapy, less than 2 hours is recommended. Ensure is intubation, surfactant, and extubation to CPAP. This is a method of giving a surfactant to the preterm baby. And also these guidelines recommend that there is no role of prophylactic surfactant in preterm infants less than 28 weeks of gestation. A word about lung ultrasound score. So this is a new technology. Because nowadays, point of care ultrasound machine is available in almost all tertiary care analysis. So in that cases, lung ultrasound can be good adjuvant because to determine when to give surfactant. So this is upcoming modality, and many articles have been published recently about its use in predicting which babies require surfactant. So in that, there are scoring systems which are available. So in that we score both the hemithorax at 3 areas: the anterior axillary, posterior axillary, and hemiclavial lines. So this, you can see this image where you can see the underneath this pleura. This is the pleura. So underneath this pleura, you can see the horizontal curvature articles. So this is a normal lung, and there is no problem with this lung. So we score it as 0. In the score of 1 is given when you can see the V profile. This is called as A profile, the horizontal reverberation. The V profile is the vertical reverberation, which is mainly seen with RDS, and there is a lot of fluid in the lung, and you can see wet lungs can be seen. The score of 2 is given when there is a total whiteout, this kind of image you see on the lung ultrasound. And the severest one is when you see that the pleural line is broken at places, and you see the V profile or multiple V lines. So you can see the score is calculated at these 3 areas. The maximum score can be 80, and anything more than 8 predicts the requirement of surfactant therapy irrespective of fluid FIU. So these are the trials. The recent ultrasound trial in 2020 in Barcelona. They did 56 minutes, less than 32 weeks gestation, and respiratory distress syndrome. So they did an ultrasound in these babies, and they found that those with lung, with the use of ultrasound group, in babies received surfactant earlier, that is 1 hour of life versus 6 hours in the traditional group, and had greater saturations and SpO2 and FiO2 ratio after the surfactant therapy. So you can see that the positive, the time to action and the positive outcome of the surfactant with the help of ultrasound guided surfactant therapy. This is a recent multi-center trial in 250 units where they used unital lung ultrasound for prediction of the requirement of surfactant. So what they found was lung ultrasound predicted the first surfactant administration with a good accuracy of with area under curve of 0.86 and had a sensitivity of around 79% and specificity of 80%. And they concluded that the lung ultrasound is a reliable criteria for administration of surfactant therapy treatment. Now coming to the types and the doses, how much doses, single dose, multi-dose, and what are the types available to us. So surfactant are mainly the natural surfactant which are most commonly used. These are animal derived but they can be costly and can also be immunogenic. Synthetic ones are mainly which are synthesized in labs using examples are surfactant and so the natural surfactant are good. They are derived mainly from the porcine lung cells, the calf lung cells, and the bovine ones, either the lung extract or the lung cells. So these are the Surfactant alpha, Surfactant, Surfactant, and rest which are commercially available to us for treatment of IBS. So the evidence regarding which surfactant to use is not very robust, and we have this. So there's no advantages in terms of mortality or incidence of BPD with any of the animal-derived surfactants. So this was the Cochrane review in 2014, where they studied 16 studies and they found that there's no difference in mortality or incidence of BPD. However, there were only the significant difference was between Curosuf and Neosuf, that is the porcine versus bovine extract. There was a higher risk of mortality and risk of death and oxygen requirement at 36 weeks with the use of bovine extract. There was a marginal difference between this Curosuf and the porcine and the bovine surfactant. So the NNF 2020, mainly based on this single review, suggested that Surfactant alpha may be used. However, this is a weak recommendation. And multiple doses of surfactant can also be used in breeders who do not show improvement with the first dose of 1 year and who still satisfy the criteria for surfactant administration. That is the FiO2 and the peak criteria. Now coming to the techniques, this is a much area where there are multiple methods are coming up for delivery of surfactant in preterm. So we have this invasive, less invasive, and the non-invasive ones. The invasive is the classical one, which is the intubation, surfactant replacement, and extubation to CPAP. This is the most widely practiced method. But recently, the less invasive one, which is the LISA, MIST, and SALSA. LISA stands for less invasive surfactant administration. MIST is minimally invasive surfactant therapy, and SALSA is surfactant administration through laryngeal or supraglottic airways. So we'll be seeing the insured and the LISA techniques in this session. And the non-invasives are the nebulized surfactant delivery, where we even do not require to intubate or open his mouth. You can just give it by your nebulization. So all of these being studied. So coming to the classical technique, that is the insured technique, what we require are these equipments or instruments like endotracheal tube, proper size, a feeding tube, a syringe, surfactant, a measuring plate, and a surgical blade. Nowadays we are having this endotracheal tube, this side port, where we do not need the feeding tube, we can just give surfactant to the side port. So what is insured technique is to intubate the baby first, then give surfactant, then extubate to the CPAP. Give positive pressure ventilation before extubation to CPAP. So we do not. There are widely practiced methods how much positive pressure ventilation we should give and for how much duration. So this varies from different centers to centers. So this is just a video demonstration how you do the insured technique in a simulation model. Proper hand washing is very much required. As told already, the equipment should be kept ready in a sterile trolley. The baby is initially put on positive this continuous positive airway pressure. You cut the feeding tube to match the length of interceptor tube. Fill the appropriate dose of surfactant in a sterile way in a syringe. We require 2 people for administration of surfactant. One will intubate the baby, will intubate the baby with appropriate sensitive trachea entry. Give some positive pressure ventilation. Then administer the surfactant. The second person will administer the surfactant. Give positive pressure. The surfactant is given in boluses, not like if the dose comes around 5 ml, you should not push all 5 ml in one go. You should give in boluses of 2 or 3. And after each bolus, you should give positive pressure ventilation with the help of your amplifier or resuscitator. And then thereafter, after some time, you extubate the baby to continuous positive airway pressure. So this is how the in-shore technique is done. Coming to the less invasive surfactant administration technique or the LISA technique, where one performs where a continuous positive airway pressure is given throughout the procedure. We do not remove the CPAP. CPAP is given throughout the procedure. Then we do a direct laryngoscopy and insert a Surfactant. So thin catheters are available, commercially also available to give surfactant in a less invasive technique. Or we can use this very thin 5-number feeding tube as well. So we have also tried with 5-number feeding tube. The problem with 5-number feeding tube will come because it's not stiff. So it might not be very much easily passable. But if you the commercially available Surfactant insertion is also and then if you surfactant, and the CPAP is continued throughout the procedure. We do not remove the CPAP. So the positive airway pressure is also maintained, and we also give surfactant. So the evidence for LISA is coming up recently. This is offering systematic review of 16 studies where they enrolled 2,000 neonates, around 2,000 neonates. And their surfactant was administered with thin catheters. And they have found that it is associated with reduced risk of death in BPD, less intubation in first 72 hours, and reduced incidence of major complications in hospital. So the NNN 2021 also gives that LISA may be preferred or insured in setups where there are expertise in less than 34 weeks of gestation babies. And use of LMA should not be used. Currently, the LMA is also coming up to give surfactant in RDF baby, but presently it should not be used outside the research context. Now coming to the effects of surfactant therapy, once we have given the surfactant to baby, what will happen in the lungs? So there will be increase in compliance and improved oxygenation. The pulmonary circulation also improves. There is increase in pulmonary blood flow. You will see the resolution of features of RDS in your chest X-ray. So this baby requirement decreased, they improved, and we were able to wean this baby to room. What could be the complications? The complications mainly are because of during the procedure, there can be transient hypoxia and bradycardia. And post procedure, there can be, if you do not decrease, because once you give surfactant, the compliance increases. So whatever settings you have kept the baby on ventilator or your CPAP, you should try taper it off rapidly, because the compliance increases, and if you keep on giving so much high pressure, there can be chances of dying. Other complications include the pulmonary hemorrhage as well as transient decreases in cerebral blood flow or blood pressure. Other than the primary RDS, surfactant can be used in meconium aspiration syndrome, pneumonia, dilated hernia, and pulmonary hemorrhage. So this is a case of meconium aspiration syndrome of 59 with a 3 kilo baby. Though he was vigorous, above 5 and 7, he developed labored breathing and required CPAP and was shifted to an ICU. There were retractions were persistent and saturations were less than 80% 40% of FiO2 and peak requirement of 7. The Downey score which we use in term babies was around 8 by 10. So in the management, this baby distress persisted and we had to intubate this baby and he required almost 100% of oxygen. Even though in that also he was not maintaining saturation and the gases were showing persistent hypoxia, so we started him on a high frequency oscillatory ventilator. Still the saturations improved very minimally. And this was the chest X-ray where you can see the hyperinflated lungs and the aspiration of, you can see the saturations basically which are this component which is the baby has aspirated. So at that point we gave him surfactant and within 30 hours we were able to stop the high frequency oscillatory ventilator. We gave it to assigned mode. The baby was expectantly on day 4 of life on CPAP and then gradually weaned off on day 6 and discharged on day 18 of life. So what is the evidence? So in late preterm and term neonate with severe MAS or severe pneumonia which require invasive ventilation with oxygenation index of more than 50, the surfactant can be tried. And much of this evidence comes from the systematic review where they have included 326 in post-studies where they found that the surfactant, even though it did not reduce the mortality, it did reduce the duration of hospital stay. So you can try giving surfactant in cases of MAS and severe pneumonia where you are stuck. The evidence in early term and late preterms, babies with RDS who satisfy the criteria of surfactant therapy with peak of more than 7 and FiO2 more than 40, surfactant may be tried. And this is the evidence which included say 17 studies where they found that there is a potential decreased risk of mortality, air leak, and PPHN and division of respiratory support in these babies. So now we know that when we are going to use surfactant, but we should also know when we are not going to use surfactant. So the recommendation from NNF guidelines is when we are not going to use in preterm neonates who present with respiratory distress from a different hospital to your hospital beyond 72 hours of life, irrespective of whether you receive prior surfactant or not. And also, there is no rule of giving surfactant along with corticosteroid intrathecally as an adjunct in less than 34 weeks. So, this situation should be avoided. In low and middle income countries like India, what is the role, the efficacy and safety is for preterm units with RDS. So, this study was published in 2016, the review. Where they found that there were two OCTs in 22 observational studies where they found there was a decrease in mortality, invasive surfactant replaced therapy, decrease in risk of air leaks. However, there was insufficient data on DPG incidence and failure rate were around 34 to 45%. So, coming to the conclusion, we know that the surfactant replacement therapy and CPAP are standard of care in preterm units with respiratory distress. Surfactant has a role in neonates with volume aspiration syndrome, pneumonia, and some in bronchopulmonary prevention of bronchopulmonary dysphagia. Early rescue therapy is most effective in improving the outcomes. No difference in various types of natural surfactant in terms of efficacy is there, but there may be some evidence for good acting alpha. In-shore technique is most commonly used method for administration, but however, these have advantage of being less invasive. Transient hypoxia, apnea, and pneumothorax are immune complications. There is still more to explore about the role of tracheal budesonide and surfactant combined in prevention of DTT, use of nebulized surfactant. The evidence is still lacking in this regard. Use of maybe synthetic or lab-made surfactants. So there are more to explore in this area. Thank you for your patience.